Okay, so I'm going to try and balance holding my notes, because as we've heard, I've never delivered some of this material before, and there's a couple of bits of it which are quite technical, but it is quite nice to have the opportunity to come and try this out today with you. It's using data that we've been developing over the last 2 to 3 years to tell us about how the structure of services interacts with the delivery of care, and I think that's a lot of what you've been discussing this morning. Just get this in the right place. It's also very prudent of you to have brought me here this week, because after next week I may not be able to come back to Belgium, subject to what happens in the referendum next week. So we're about a week out from that, and it's probably fair to say that there's a developing nervousness amongst my political leaders about what the likely result of that might be, which may be a nervousness that wasn't there a couple of months ago. So, let's start with Scotland. So, what is Scotland? Scotland is, I think this shows the problem when you transfer from Keynote to PowerPoint. It's a population of 5.3 million people, so it's around half the size of Belgium. This year we will spend around £13 billion, around 14.5 billion euros on healthcare, and we'll spend around £3.3 billion on social care. What we've seen in recent years is that both of those budgets have been rising. They've been rising at least in real terms, and also in cash terms, although as we've seen in the discussion, that's against a growing challenge around demography. In terms of how we organise healthcare within Scotland, we deliver it through 14 geographic health boards, and those health boards historically managed primary care, as well as hospitals, as well as community healthcare. So they brought that together into I suppose you might describe it as a partially integrated healthcare system. And alongside that, we had 32 local authorities providing social care, along with other functions like housing. And again, able to bring that together with a broader range of social care services. Just about all of the healthcare that we offer in Scotland is free at the point of delivery. So there is no co-payment, there is no insurance system. It's the same model as the NHS in England, albeit it was formed 1 year later. And in terms of social care funding, almost all of that is paid for by the state through resources passed to local councils or through the resources that councils themselves raise. So almost none of the health and care system that we delivered is paid for directly by the person receiving the care. They of course pay for it indirectly through taxation, but it's a whole system which enables us to bring the resource together. I imagine over this week and last week and next week you'll have an interest in the European Championship, but I should just draw your attention to the fact that this is an area that Scotland has also decided not to participate in. Although, as my First Minister, Nicola Sturgeon, helpfully tweeted to the rest of the UK recently, and indeed I guess the world, that was only to give the other countries a chance, which I should mention is a chance that Scotland has been given the rest of the world for a number of years now. As I'm myself from Northern Ireland, I feel comfortable saying that, and expressing a degree of commiseration with many of my colleagues. So, what's the challenge? And I could offer you many graphs at this point showing how things will change over the next period of time, but it boils down to a few key statements. So we have greater public expectations being made of the health and care system. We have more people who are living longer and indeed living into very old age. We've got an increasing prevalence of illness and an increasing incidence of illness, particularly chronic conditions. And the data that we've developed in Scotland, and I'm not showing it today, shows that more people under 65 have more than one chronic condition than people who are over 65. So chronic conditions isn't just an issue in relation to ageing. Although, interestingly, that group of people under 65 are not significant users of hospitalisation in relation to the over 65. So clearly, if you're younger, the likelihood is in Scotland that you'll be receiving much of your care for your chronic condition in the community. We're seeing this being supported by new medicines and technologies, and each year or every other year we will see some new high-cost drug or treatment appear. And certainly talking about this with other healthcare systems, we can see 5 or 6 that we can identify which have appeared in the last 3 or 4 years. And we can see how we can currently accommodate those within the funding envelope we have. But if we multiply that over the next 10 or 15 or 20 years, when we have 30 or 40 or 50 high-cost treatments, it really begins to raise questions about how we accommodate that in terms of how we support healthcare. And this, alongside health inflation, which runs higher than general inflation, is making healthcare less financially sustainable year by year. And that's the challenge I heard this morning, in that while it would be nice to continue as we are, and it would be nice to continue to grow the model in the way in which it's currently shaped, it's predictable, it's understandable, the resources that we have available and that the resources we're likely to have available in future years don't allow us to do that. And there's a question which is, even if we had more money, do we want to continue to spend a greater share of our GDP each year on healthcare? Because there will be a limit to that in terms of what can be sustained. Alongside that, and I think it's a point which is less made, we also have we don't just have a sustainability challenge, but we also have a quality challenge. In that we're not seeing significant quality gains from year to year as we spend more on healthcare. There's a sense that we are coping or accommodating additional demand, but that in terms of the things that people say matter to them, in terms of maintaining normal life, maintaining relations with family, feeling in control of their life, feeling safe, those things aren't changing significantly. So while we put more money into the system to support how the machine operates, what people experience isn't always what they want. So our politicians have reflected on this, and I'm going to offer you what is quite a long quote, but I'm going to take a couple of points out of it from what our Deputy First Minister, who was also, until the recent election, our Finance Minister, who's now our Education Minister, said when he announced the budget in Scotland in December of last year. So he said that the nature and scale of the challenges facing our NHS, in particular the challenge of an ageing population, means that additional money alone will not equip it properly for the future. To be blunt, if all we do is fund our NHS to deliver more of the same, it will not cope with the pressures that it faces. And the discussion that you had this morning about whether you would be able to identify or secure additional resource to put into the system is a discussion that we've had as well. And we will continue to add additional resource to the system, but our view in Scotland, and we think it probably applies in most places, is that simply adding more money will not solve the problems that we currently have. We need a different sort of solution. So our ministerial team, since last year, in the context of generally being cautious about change, looking to reassure the public that things will stay as they are, because the public fears change, have begun to develop a rhetoric and a narrative which is about reform. And they have talked about the need to use the resource which is in the health and care system to reform the system. This was also shown in their manifesto. So protecting investment is vital, but the shape of our NHS and care services also needs to evolve so they are fit for generations to come. And that word shape is a word that you're going to increasingly hear in the Scottish context. It's how we talk to ministers about the challenge, and we've talked to them about the balance between different types of service and the ways in which those services meet the needs of individuals in the community. So shape is a key component. And we saw a lot of graphs this morning about OECD tables showing comparative shape in terms of hospital, and also some of the distribution across the country, but within Belgium as well as the health. But shape is a key component of the change process. An aim to deliver care as close to home as possible. Now, this has been our aim in Scotland for 7-8 years now. We've had a 2020 vision which has talked in terms of moving care closer to where people live. We have struggled to do that alongside maintaining hospital performance. So we've tried to keep things the same and change things at the same time, and it hasn't worked that well for us all the time. So I think we're now at an inflection point, a point in the process where unless we do what we've said we will do on the change side of the equation, things will simply not be sustainable. So, and ministers have coined and started talking about a community health service. And it's interesting because they know within Scotland the word health and NHS, it resonates more strongly than the idea of social care. So it's a powerful engagement with the population. So talking in terms of a community health service is intended to provide reassurance that this is still a health service. And it's not a health service on the cheap, it is a health service focused on quality. Finally, they made a very clear commitment that over the next 5 years, the 5 years of this Parliament, that they will move expenditure, and that will be auditable, so it will be demonstrated in our accounts between the share that is spent on hospitals and the share that is spent on community services, whether those are social care or primary care. The government was subject to an audit report on health and care in September of last year, and then again in March, immediately prior to the election, which identified that even though we had made the commitment historically to shift the balance of care, what had actually happened over that period of time was we had spent more money on hospitals. And that had been in the context of challenges around winter and around A&E and around things which were effectively things which appeared very much in the public domain. So they've now made a very clear and transparent commitment that that will change. So thinking about that, so we now have a clear political mandate for the nature of the change. One of the challenges that we have is to actually understand how that will actually apply against our geography and our shape of services. And so I'm now going to show you some of that data, which other than in private I haven't showed anybody before, so I'll see what you make of it. One of the first things that we've been looking at is this question of rate of hospitalisation. So in this graph what I'm going to show you, which is for people who are 65 or over, what percentage for the different areas of Scotland, and I've used the council areas, the 32 council areas, what percentage of the population is in hospital in an acute, unplanned bed, so it's an unplanned admission, it's not for scheduled care, it's not for elective care, on any given day of the year. And what it gives us is this spectrum. So at your far left we have areas like Aberdeenshire and Moray, and they have a hospitalisation rate for over 65s which is 0.4% of the population. So that's just over 1 in 200, and that's the area around Inverness and around Aberdeen. At the far right of the graph, what we have is we have Glasgow City alongside Inverclyde, City of Edinburgh and West Dumbarton, urban conurbations, and what we're seeing there is rates between about 1.45 and 1.6. So that's between about 1 in 60 and 1 in 65. So what we're seeing within this is a threefold variation in the rate of hospitalisation for over 65-year-olds. Now, if we imagine when we look at this, we're looking at half of all the hospital bed use in Scotland in a given year. That's quite a significant figure. So if all of Scotland used beds and hospitalisation at the rate of Aberdeenshire on the far left, that would allow us to close 5,400 hospital beds out of a total of 13,700 beds. And it would enable us to release somewhere just short of €1 billion in expenditure each year. So the variation, because quite often we have conversations about rates of variation between here and there, and we can have the discussion about prescribing practice between one GP and another GP, and we're looking at hundreds of pounds or thousands of pounds. When we look at the differential rate of hospitalisation in Scotland, we're looking at a variation which is effectively in our currency worth around £890 million each year. And it's not just money, because we know that people who come into the unscheduled care system are more likely to be discharged to a social care setting. They're more likely to lose connections with family or friends, and they're more likely to lose functionality. So they are not just costing money, and that's not the motivation here. The motivation here is better health and care. They are more likely to have an ongoing range of poorer outcomes in terms of what happens to them next. We can show a bit more to go with this, and this is coming back to this idea of shape. So I'll put in, this is the services, this is the previous data put into this graph. So that's exactly the same data you've just seen, but the scale on the left, as you see, is now greater. If we now add in some quite interesting, the Ochre brown, but that's just added on. Those are community hospitals. Those are small-scale local hospitals. Some of them might have 10 or 15 beds, but also which tend to be run by primary care physicians, generalists, and they tend to be in more rural areas. So we're already beginning to see something which suggests that smaller local hospitals providing some functions have a function in reducing the hospitalisation rate in big central hospitals. We can add in this next column. This part of the column is residential care. So those people who are in nursing homes within Scotland. And again, we're seeing a fair degree of variation in the overall shape of the system. So part of that is to do with supply. Part of it is to do with patterns of placing behaviour. Part of it's also to do with the degree to which people step out of the state-funded system and purchase for themselves. So a particular area there in East Dunbarton, which is the particularly low item in the middle. But we can then also add in this group, and this is people who are receiving 10 hours or more per week of care at home. So these are people who would have some form of home assistance, but which is 10 hours or more. And again, we're seeing a degree of variation within those columns. So I could show this, I could build this in a number of different ways, but the takeaway from this is, for me, is once you add each of these elements together, you see very different patterns of care manifest across Scotland in very different networks of care. The variation between the top and the bottom now is the variation between about a 9%, so just under 1 in 10, just under 1 in 10 people within Scotland, within Glasgow City, in some form of institutional care, and a 1 in 20, or a 1 in 25, which is the East Dunbarton or the East Renfrew. So again, a real differential. So we might begin to wonder, why would that be? Why would we have that range of figures? And people have good theories about why that would be. So I'm going to come on to a couple of those theories and look at some data related to those as well. So just give me a sec to catch up. One of the consequences, and it comes a bit to the, sorry, I'll add this slide is that as you roll the clock forward and imagine what demographic change will mean for your system, and this is quite a complex slide, if we look at it and understand it and imagine that it happens evenly across Scotland, we see the blue columns. So that imagines that the average is what applies in terms of the requirement for bed days. The scale on the left is occupied bed days, and it's quite an easy thing to remember how many occupied bed days we have in Scotland for unscheduled care, for unplanned care. It's about an average of 1 per person. So we have about just over 5 million occupied bed days per year in Scotland in 2013-14. If we roll that forward on a Scotland average, by the time we get to 2037 or 2032, we're looking to have grown by about 40%, an additional 2 million bed days. But if we were running the system running forward as though it was Aberdeenshire or Murray or 1 or 2 others, we actually have a surplus of beds in 2022. And that surplus only really begins to disappear once we get to 2037. The bigger challenge for this, though, is how this is felt in some of the larger bits of the system. So if we see this roll forward in the way in which we would expect to see it roll forward in Glasgow, which is the largest local authority area in Scotland, the impact there is almost a doubling of beds using the current service model. So what that's taken us to understand is that if we're looking forward to project what future demand is and the impact of that demand is, we have to disaggregate from the national down to each of the local systems and then rebuild the system back up. Because simply applying averages will give us a distorted picture of what the impact of change will be. It also gives us an interesting question, which is, if you, and we'll come to this shortly, if you believe that and know that Glasgow has significantly more beds than most other areas of the country, does that mean it will be easier for them to accommodate demographic change? Or will the fact that the behaviours and processes and systems largely channel people towards hospital make it more difficult? Do they have the latitude to bend what they do? Or will they have a harder time than Aberdeenshire, or will Glasgow have a harder time? But this is important in terms of understanding the impact of demographics, and that those will not apply equally across the system. They will apply into the system. Generally, when we show this data, what people tell us is this is the consequence of poverty, and you would expect Glasgow to have higher rates of hospitalisation and some of the areas in the west, because there are more poor people. So we dug into that and we decided to do an analysis, and we have linked data in Scotland which enables us to build this. Each of these, this is modelled, but each of the previous graphs that you've seen is based on 4 million case records aggregated up into the bars. So we have the linked data which enables us to do it at a national and local level. So we looked at poverty. On this, I've taken the three of the northwestern boards, which are at this end, and the 6 partnerships, the 6 areas that work with Glasgow Health Board at the far right. And for each of them, moving from left to right, you see, at the left you see the poorest people, and at the right you see the most affluent people. And what that gives us is a mixed story with some degree of variability between the areas, but we're not seeing a hardwired connection between poverty and use of beds. We're seeing it's fairly flat, and I've brought that out more clearly by putting Glasgow City directly beside Murray, which is the area beside Inverness, where the pattern of deprivation is pretty much the same, even though in terms of the use of beds, even though Murray is a considerably more affluent area than Glasgow City. So what we're seeing is, in terms of bed usage, it's not being explained for us by poverty. We're seeing 100% variation in the number of beds being used, the number of bed days, but that is not in any way linked to a differential social context. If we move on, we look a bit here at hospitalisation in the last 6 months of life. And what this tells us, and again this is data based on the linked data that we have, is that we have a variation of between an average of 14 days in hospital and an average of 28 days. So again, 100% variation between areas of Scotland. Showing that in, again, Aberdeenshire, Murray, Orkney, Shetland, at this end of the graph, you're a lot less likely to spend significant periods of time in hospital than you are at the far end, which is Glasgow City, City of Edinburgh, East Lothian, South Ayrshire, and areas like that. If we understand this as an average, this is built up from, it suggests to us that in those areas there are significant numbers of people who are spending most of the last 6 months of their life within hospital. And one of the things I suppose I was surprised not to hear a lot of this morning was the growing impact of dementia, because when we step in and look at this data, increasingly we identify that significant numbers of those people who are spending long periods in hospital are people who are being admitted appropriately to hospital, are not inappropriately in hospital, but are there primarily because of illnesses or behaviour linked to living with dementia. There are good models of care which would provide care in the community, but dementia having largely appeared recently in the scale that it has, those models aren't really well embedded within Scotland or indeed anywhere else. But it's a main service change area. Again, 100% variation. So we took a look at, and we had some discussion of this morning, delegated hospital beds per capita by partnership. If you just ignore the title, which is perhaps a bit technical, what this says is that how many hospital beds per 100,000 do you have in each of those areas which you've seen across the board so far. And you see the ones which I've starred there, which are Edinburgh City, Inverclyde, West Dunbartonshire, the Western Isles and Glasgow, are the ones which were at the far right of the graph in respect to hospitalisation. Here we're seeing something over 100% variation. It ranges between about 140 beds per 100,000 and 320 beds in Inverclyde. Glasgow City is sitting at around 280 beds. What this shows us is that there is and we had some discussion of this morning, there is a significant supply side component to the structure of services. It shows that basically if you have the beds, those beds will be used, and they become quite dominant in the model of care that you're actually using. In terms of how we use that data, though, it's quite challenging, because the answer to how you address the differential patterns of service, the differential shapes of service, isn't simply that I would write to the Chief Executive of Glasgow Health Board and suggest to him that he might want to close around 300 beds. In that these beds are part of networks of care. They're based on behaviours of the population in terms of who attends to A&E. but they're also based on behaviours of clinicians and networks of care. They've also developed in a way which has meant that other community services haven't developed. So it's not simply for us a discussion about changing the configuration of beds. You require a more fundamental change across how the system actually operates, in that those beds work well at the moment within the existing model of care, but they are part of a web of different components of that model of care. And so it requires care and management to actually move through the process of changing that shape. And as I've said, you're looking at more than 100% variation there. So to come back to this, and in some ways this slide with its 300% variation drives a lot of our thinking at the moment. It gives us the question, how do you engage with that, both to avoid the challenges of demographic change and how that might apply across the system, which could be catastrophic in some areas, but how to think through how you produce quality and safe services for people, which isn't simply about taking beds out of the system. So I'm going to say a bit about what our strategic approach to that has been. I'm going to talk a bit about health and care integration. This morning there was some discussion about where you would find the solution to many of the challenges of the hospital system. And in some shape or form, the Scottish Government has been working on health and care integration since around 2000. So we're about 16 years into this process. It took us until 2011, and the previous Deputy First Minister, the current First Minister, Nicola Sturgeon, announced that she would bring forward legislation to integrate health and care. And I'll break that down in terms of what she said that we would do. So she said we would bring together adult health and social care services, although we've since extended that to children's services as well, to bring those together around the needs of individuals, their carers and other family members. So it would be based not on the needs of the system, but on the needs of the individual. They would, while there would still be health boards and there would still be councils and there would still be providers, people would be held jointly accountable for the outcomes. So there wouldn't be hospitals being held accountable for hospital outcomes and community being held accountable for community outcomes. The accountability would sit across the piece so that people would share the successes and the challenges. Financial mechanisms would support that. Now, we currently largely fund on the basis of single grants to each of the organisations, but those historically have been separate grants, which means that you've got health money and you've got social care money. And there's an element a couple of times this morning where people thought about things which, if they did it, would give savings to others, or if they didn't do it, would give costs to others, what we in our system would call cost shunting. So we decided that we wanted to ensure that the financial arrangements were such that as we moved forward, that resource would be focused on delivering the better outcome rather than on protecting the organisational interest of a particular organisation. But also within this, and a key message for us was the degree to which there would be strong clinical leadership of the redesign and the development of services, and a view that unless clinicians were part of the story, that it was unlikely both to have credibility or to be successful. And I think year on year, and I've worked in health in Scotland since 2004 now, each year I've seen a greater role being played by clinicians, and I'll come back to that. In terms of the principles, and this is the learning that we've taken from work and meetings across the world, is think about populations and the best way to meet the needs of populations. And if you think back to the previous slides, that's a bit about how the system has developed already. So where you've got, and we're increasingly talking about having 30 to 50 different healthcare systems within Scotland, rather than the single healthcare system that we maybe imagined that we had. Think about how you bring resources together, ensure clinicians and care professionals are part of the process of commissioning care and delivering care, but offer strong leadership and focus on outcomes. And I guess that's where Scotland's interest in the work of ICHON is, in terms of taking a more outcomes-based approach more generally. In terms of the key ingredients of the legislation, and we completed the legislative process, so this is now on a legal footing in Scotland, nationally agreed outcomes, integrated boards that have responsibilities both in the delivery of services, but also the commissioning. So they're a wee bit like ACOs, they're accountable care organisations, but they also have the governance role. So they're not simply the provider organisation, they also are the strategic organisation. Single local budget for health and care, and operational integration of services. And that's developing in a variable way, but increasingly we're seeing that the areas which are moving fastest are doing that. So that's integration. I'll mention also, and I'll do this quickly, our recent national clinical strategy. And it again reflected a number of the challenges that you talked about this morning, but came out of some of the evidence around safety, questions about clinicians and hospitals doing relatively small numbers of procedures, where the quality was less than it would be had they done greater numbers of procedures, but also the use of clinical networks and the greater use of outpatient and day patient. So we published our national clinical strategy in January of this year, and it offers a new clinical paradigm. It's intended to, led by clinicians, delivered by clinicians, will be taken forward by our medical directors. It reflects on the fact that increasing investment has diminishing returns as we go on. That often the question is, could you do this more efficiently? The question is, should you do this at all? Or is there something else you should do? And the productivity and efficiency analysis doesn't take us there. The productivity and efficiency analysis locks us into the current system. An understanding of the need to have a different relationship with patients, to have open and honest discussions about the benefits from approaches or from different interventions, maybe that we haven't had before, and a different sort of clinician, but also a process whereby we seek feedback on outcomes, that we understand the benefit that this is achieving. And again, some of this comes back to the work of Michael Porter on value-based healthcare. What we think that will bring for us is a reorganisation of many services, and the examples I've given here are prostate and complex cancers. I think prostate got a mention again this morning from your minister. Orthopaedic and vascular services, whereby you begin to bring those together in single centres or regional centres, but as part of networks of care to allow for day case and outpatients to be handled more locally. We would expect outpatient diagnostics day case to be done in almost all hospitals, but overall the number of inpatient units doing elective and unscheduled would reduce. We would maintain standards of quality around acute care, and would look to extend those, but on the basis of a different shape within the hospital system, but also building care across clinical networks. So understanding that doctors increasingly would work within the community as well as within the hospital setting, and would maybe spend 3 days of their week in Glasgow doing particular procedures, but then a day in Ayr doing follow-up outpatient appointments, and maybe a day further away down in Stranraer doing first appointments, doing first evaluative appointments. So seeing how they actually operate differently across the system, but understanding that as care pathways. Interestingly, in the meetings that we did at ICHOM a couple of weeks ago, when we spoke to Karolinska and Erasmus and Cleveland, each of those organisations talked about how they were reorganising their care pathways in a similar way, which suggested that sort of model of care, which is rethinking how multiple hospitals engage with the clinical population, is the way ahead. A second element that came out around the same time, and which was mentioned in the paper, but is also mentioned in our Chief Medical Officer's first report, Catherine Calderwood appointed it last year, is the idea of realistic medicine. And this is the idea that some of the things that we've been drawn into year on year are maybe not necessarily for the best benefit of the patient. And some of these are quite difficult ideas for politicians and for senior officials to put forward, in that the narrative has always been about more or faster or better. But often when we look at how we offer benefit to patients, that may be in some cases less or not or different. So trying to think about better how we manage risk, how we work with networks of care, but also looking to step back from overdiagnosis and overtreatment, looking more clearly at the relationship between intervention, risk, and broader, I guess, personal gain or loss. Certainly the assessment is not just, so we're not just talking about procedures of limited effectiveness or with poor evidence, but we're also beginning to look at those points where we would step in heroically to offer interventions at a point where you probably really are in end of life, and that palliative or hospice might be more appropriate. So more honest conversations in that space to, again, change the dynamic of the nature between clinician and patients, but also just understand that in terms of the broader healthcare. And key within this, avoiding a medical response to social problems. Understanding that social problems require an appropriate social response. So in one of the areas that we're looking to measure, increasingly what we're focused on is things such as isolation and loneliness as a key component, which will not be treated by a clinician. Isolation and loneliness will be treated by different types of service, but has an impact across the system. So, integration of health and social care, pooled budgets, a new clinical strategy to rework how we deliver care across the hospital system. And to be fair, we can do that because we run the hospital system. My colleague who has the office across the room, the corridor from me, is the Chief Operating Officer for Scotland. And so he has the ability to decide how we will redesign that, subject to some local politics, which I imagine you have as well. And then we have the paradigm of realistic medicine. So thinking through how we can join each of these elements up to give us a more sustainable system. And that's broadly where we are at the moment. I'm going to mention two things that we do to support that. You've seen a bit of it already, but in terms of supporting actions, now some of you may recognise this. This, of course, is Moneyball. Helpfully, my spell checker corrected it in my notes to money bag, which of course is not what we are going to get in health, but this is Moneyball. And this is the idea that what we do needs to be underpinned by data. So I was impressed by the material that the 3M people had out here, although it's still a sort of a limited chunk of what you might want to be looking at in terms of the data. The use of data that we've been able to have in Scotland has changed how we understand how healthcare is delivered. Now, I'll give you one of the graphs which I think has had one of the most telling impacts on how my Cabinet Secretary and the Cabinet in Scotland have seen the issue, which is this graph here. High resource individuals are those people within the system who use the most resources. So a simple concept, and we're able to do that because we can identify the costs associated with hospital stay, with elective procedures, with primary care services, with pharmacy and with social care, and we can basically bundle those together. So I'm going to give you a graph here which shows, it's for one of the integration authority areas, one of those council areas. It's 150,000 people. And this sliver here on the far left, this tiny little red piece here, it's 2,600 high resource individuals. And between those 2,600 people out of a population of 150,000, they use 50% of all the health and social care resource within that area. So we think of ourselves as a national service, a general service, a population service. How we use resources is nothing like that. We had mentioned, I think, this morning of the data from Canada, which was 5% using 60%, but this is 2% using, and this is consistent across Scotland. It's a wee bit of variation from area to area, but the variation is between 1.5% and 2.5%. It's not between 1% and 10%. If we add in the next group, and I'll bring them all up. So what we have is we have the secondary high resource individuals, the second group. So the next 10% of the population, they use 33% of the resource. And the group beyond that, the lower resource individuals, 31% of the population using 14% of the resource. What that gives us at the end there is 57% of the population use 2% of the resources, and indeed about 30% of the population, 20% of the population in any year use no resource. So as we're beginning to plan and think through what the nature of the primary and community response is, we know that the key component of work in that area is working with this small group here, is building services in the community which enable us, because nearly all of that resource is associated with hospitalisation. So we now know who they are, and we also know the care pathways that cause them to use that resource. And in most cases, those aren't because they got excellent clinical outcomes. They are because they had excellent clinical care, and our hospitals, we're proud of what our hospitals do, and I'm sure you are as well. But the basis on which they ended up in hospital in the first place, in some cases was unnecessary, and in many cases was definitely preventable. So it requires those services and systems to do that. So that just shows all the different sort of data we can pull together. But we are the envy of the rest of the UK, and for most systems in terms of what we can do at national level around data. But it's changed how we understand healthcare. Strangely, when we speak to clinicians, they said, yes, we knew that all along. I just wish they'd told us before now. We support change. We have a national integrated change support agency using quality methods. We work with the Institute for Healthcare Improvement in Boston. We work with the Health Foundation. And we offer support partnerships as they go through redesign, both in terms of the technicalities of that, but also the capability. So we have a what's called iHub, based within one of our national bodies, which provides support to all of the different partnerships across the country to produce change. And it's got planned programs, responsive support, and it's got some small grants for test work, but our general approach increasingly is not to do pilot work or pathfinder work. On the basis that our experience is very few pilots and pathfinders actually go into practice. So the evidence would tell us, there's a question as to whether you should do them or not. It has a range of different interventions which you can offer locally. We're supported by national outcomes, 9 outcomes which aren't performance targets. I will come on to performance targets. I've got 2 or 3 minutes and I'll be done. But these outcomes are framed around improvements to health. They're framed around retaining control. They're about inequalities, so ensuring that the benefits from health are shared across the population. We also include within that safety. So these are intended to be higher level ideas rather than individual, variance-focused targets that you'd apply to the system. And it's intended to draw the eye of the system up to the ultimate outcomes that we're trying to achieve. And we're doing further work with ICHOM and others and the OECD about the indicator set that sits underneath this to allow us to track it in real time. I'm sorry about the font size, but I'm sure that you probably will get the slides and you can read it in more detail. So where does that leave us? Where are we now? This is Shona Robeson, who's the Cabinet Secretary for Health and Wellbeing in Scotland, so she's effectively my boss, has been for the last 2 years. And this is her signing into law the first of the integration schemes in February of last year, February 2015, for the Ayrshires, the 3 integration areas on the west of the country around the area of Ayr. And they've now been in action for 16 months. So our new integrated care system has been in place using the new powers for that period of time. Most other areas in Scotland came online and took formal powers on the 1st of April of this year, although most of them were working in shadow form over the previous 12 months and working as though they had vested the powers. So they'd already begun to pass money between organisations and begun to joint plan. And what's interesting for us in this is that within our system there's a lot of fear of integration, that the consequence of it would be a loss of control, in that sharing control between different bits of the system would mean that people would lose control and things would. But the challenge that we gave the integrated space, certainly during last winter and the previous winter, was to be able to demonstrate that those things which matter in terms of sustainability, so things like A&E performance and our ability to reduce unnecessary hospital bed use, could be delivered on. And I'll show you 2 graphs on what some of the early deliverables around that have been. So this first graph shows bed days lost to delay, and if we look at the far left of the graph, and the green line is probably the one to focus on because that's the overall total number of bed days lost to delay in any month for people who could have left hospital but who were stuck in hospital because they were waiting for a social care package or some community health response. That shows that we've taken it from somewhere around 60,000 to somewhere around 50,000. The slight bump up is followed by a further bump down at the end. So we've taken about 8 to 10% of the lost bed days out of the system. So that's giving us something like 10,000 bed days every month I guess scaling it up to Belgian terms, that's 20,000 bed days a month, 240,000 bed days a year, which we've already delivered through running as an integrated system. And that's effectively through speeding discharge, but also reducing admission. So we've tried to make both ends of the system work as well. And what's happened within hospital? Now, the benchmark in the UK is 4-hour accident and emergency. I don't know what your benchmark is. But what we have in A&E is we have the black graph, and the objective here is to be as high as possible, in that our standard is 95%. As you can see, we've probably touched it, 95% during the 15-16 season, which is just over. But the gain that we've seen between 14-15 and 15-16 has been quite significant. So if I look at each of these last two graphs, what that tells me is that over the last 18 months, during the time when the NHS in England has seen a significant reduction in A&E performance, a significant increase in loss of hospital beds, in Scotland, working through integration, we've seen the reverse. So a 15% reduction in lost hospital beds, and a 3 to 4% improvement in A&E performance, even though demand, as it is for you, is increasing year by year. So that's where we are. We're still early in the process. We think we have a coherent strategy in terms of what we're looking to achieve. It is subject to local politics. I imagine were anybody to try and close one of your hospitals, that local communities would have an interest in that. It is challenging to change the shape of services. Clinicians will not always support it. The public will be concerned about it. But we are making progress in terms of the new models of care that we're looking to deliver. We have full engagement from the First Minister, from the political, but also from the opposition. So we have a political consensus around integrated care, but also growingly around the need to move away from targets and activity measures to outcome measures, but also increasingly to build that community and primary system. So we are in motion. We are ambitious. We are not there, but this is not something which you can identify somebody with the solution. There is no the solution. There is just what you do to get from where you are to where you need to be, and that's the process that we're in. So I hope this has been in some way helpful to your conversation. I found your conversation this morning very interesting. I know probably where I would have gone. Which side I would have sided with this morning. I think I would side with you need to integrate, but at the same time what you do needs to be appropriate for your system. So thank you.